Wow, this is a great event. I have to tell you, I have been looking forward to this for a long time. So to new friends and old, thank you for coming. And this is, I believe, the first event of its kind in the South. And this has been sponsored by the ACPMP. I would talk to them. They have actually made this happen. And look around. This is supposed to be an orphan disease. I have to stand behind the podium to make this thing go. It's supposed to be an orphan disease for which we have very few patients, except today. Today is a different thing. So this talk, I have a couple of things I want to warn you about. This is sort of flying low over Pseudomyxoma, Peritonei, and cancer of the appendix. Which I'll tell you what. To me, this is what have I been doing for the last 25 years? And you're going to find out. The other thing I have to tell you is there are some gross pictures in the talk. So I'm warning you now, for those more sensitive viewers, I'll try to warn you when they're coming up. You may want to close your eyes to part of these things. On the other hand, if you want to see the devil we've been fighting, I have some pictures of him, okay? We can see what's what. Now, everybody and their uncle knows somebody who's had their appendix out. And there's a lot of appendectomies that are done all the time. The vast majority of these are done, of course, for benign diseases, inflammatory processes, and I'm going to talk about that, not at all. Other than to say there's 500,000 of them done a year in the United States. That's a lot of procedures. About 1% of those patients who have their appendix out are going to turn out to have some sort of a tumor in it. It's not usually known before they take them to surgery. The first cancer of the appendix was reported in 1903, more than a century ago. And it represents about 0.5% of all GI malignancy, which tells you something I'm going to tell you several times, not a common process, but a very important one for a lot of reasons. Why don't we find these things early? Usually you can't find them with an endoscope. There is no screening program for cancer of the appendix, and I don't foresee one in the future, or at least over the short term. Colonoscopy, and everybody knows the appendix is, of course, part of the colon. Colonoscopy does not find these. This is a study I did, gosh, it's 10 years, hard to believe, 10 years ago already. Colonoscopy will find cancer of the appendix in roughly 3% of cases of people who have it. So this is not going to be something we're going to do, and does that mean your GI doctor missed something? No, it just means it's a limitation of what you can do. So here's one of the first gross pictures. Don't take a look if you don't want to look. I think if we can make this thing, there we go. So what you see here is an appendix, and this white stuff there is basically some of the mucin that's growing from the inside, and you can see it coming out. So this is, first I'm going to talk about benign appendiceal tumors. I'm going to take you through all of cancer of the appendix real quick. There's about 10,000 a year in the United States, and why do I say about? And the answer is because we don't really know exactly how many there are. They don't keep track of this. It's not in tumor registries. So there aren't really good data. Best estimates are in the 10,000 a year range, and I'll show you some numbers in terms of other tumors that we're going to see shortly. They're certainly more common than the malignant version. They may be, most of the time, incidental to appendicitis. So frequently when these things are found, somebody comes in, they're having their appendix out for whatever reason, and oh, by the way, there's something in it. Or occasionally we find them ahead of time. The benign versions are called adenomas, and they come in two types, Lamin and Hammond. What the heck is that? Lamin stands for low-grade appendiceal mucinous neoplasm, or Lamin. There's a high-grade version, which is relatively unusual. They're both benign. These are not malignant processes, per se. However, if they rupture and they get out of the appendix, they have the potential for metastasize, and they can be fatal. So calling these things benign is technically true, but it's not really a benign process. There's other benign things you can have in the appendix. If you find one of these before it's spread, you take out the appendix, you're done, you're cured. No follow-up, no nothing, no risk. You have a colonoscopy once every 10 years, that's all you need. Unfortunately, we don't find them that way too often. Now, here's more gross pictures. Close your eyes, close your eyes. So what you're seeing here is the different types of tumors. I'll show you some of these pictures here. This is a mucinous version. There's a carcinoid right over there. And these are the malignant varieties. And most people think cancer of the appendix, as unusual as it is one process. It is not. There are actually many subtypes. Can you hear me? Good. There are many subtypes of cancer of the appendix just to make it more complicated. To make it more complicated yet, the medical profession and the pathology department does not have its stuff together in terms of pathology. So the further back you go, if you read the original literature, the more confused you're going to get, because there are a number of descriptors which are used that you're going to see, and some of them are really informative, and most of them are not. And there still is not a unified description of what some of these things are. Most of what I'm going to talk about today is going to be the adenocarcinomas, which turns out to be the more common of the appendiceal tumors in most of the most recent data. Another gross picture. Don't look if you don't want to. Now I'm going to talk about Pseudomyxoma peritonei for just a second. What the heck is that? I have to tell you, patients stumble over this phrase a lot. They get on the internet. My doctor says I have PMP. What the heck is PMP? Pseudomyxoma peritonei, and if you were Latin scholars, and I know you all are, if you were a Latin scholar, you'd say, okay, well, it looks like it's false mucin in the peritoneal cavity, Pseudomyxoma peritonei. Again, for you Latin scholars, that's where the name comes from. This is a brand new process, first described in 1884. And what it really is mucinous ascites, or mucin in the abdomen, which sounds gross. It just does. The truth is mucin is a normal part of the GI tract. It's actually the lube that helps food move through our guts. Human beings are completely dependent upon mucin. We have to have it, or you develop a lovely disease called cystic fibrosis, which you really don't want to have. So it's something you really have to be careful. We have to have it. How does it get out into the peritoneal cavity? It's going to come from somewhere, almost always from the appendix. More than 95% of the pseudomyxoma cases come from the appendix. In fact, it's so much so, if you find it, you have to really look to see if it comes from somewhere else. We've got series of, close to 1,000 patients like this, and we have less than a dozen who have had true pseudomyxoma from things that weren't from the appendix. It can be from a high-grade or a low-grade tumor. It can be from a technically benign tumor, the lamin or the Hammond, or it can come from a malignant tumor. If you don't do anything, this is a number I want to show you over here. Untreated, this potentially benign process has got a 5-year survival rate of 10%. 10%. That is a low number. Now, if you take a look around the room, there are a lot of people in here who have really beat that number. Okay, and I think here's to them, and we'll talk more about that. The other thing is that taking out the mucin does not fix the problem. There are cells making the mucin, and I'll show you a picture of what those cells look like in just a couple of minutes. The other thing we need to know is the incidence of this disease is going up. Now, I don't expect you to be able to read some of these curves, but the incidence of appendiceal tumors has gone up over the 40 years between 1970 and 2010, 250%. 250%, that's practically tripled. And then if you take the data from there, between 2000 and 2009, it went up 54%. So we are seeing a lot more of this, I think. Now, the truth is, if you go back in time, I'm not sure all the doctors diagnosed it right back in the day. So I'm not sure if it's actually increasing in incidence, or we just have more doctors figuring out exactly what the heck you've got. But if you look at the number of cases that are in tumor registries, they're going way up. So we're seeing more and more of these. Now, this is a rare tumor. What do I mean by that? Appendix cancer, best guess, and again, the data is not super strong here. You're looking at somewhere in the range of about 3,000 cases a year in the United States. Now, that compares to 246,000 lung cancers, 271,000 breast cancers. You can read the list, it goes on and on. The thing to keep in mind is the National Institutes of Health and the National Cancer Institute, which gives out research grants to do research, they deliver their research grant material based upon the number of cases that affect American citizens. And what that tells you is they don't put up anything for cancer of the appendix research, which is why ACPMP and its foundation is so important. The other thing I'll tell you, and this does not come from science, but just a clinical observation after having been in this business for a quarter of a century, most of the patients who come to see me have never met another patient who's actually had the disease. That's a problem. Now, you can meet people online, And I'll tell you, for those of us who've got gray hairs and were here before the internet was around, it was actually harder to do before then. Today, you are not alone. This room is full of survivors and patients, supporters, researchers, all kinds of people who are interested in fighting what is otherwise a rare or, quote, orphan disease. It is not an orphan event today. Look around you. You are surrounded by people who are facing the same challenges. Also, if you do a little bit of math, now everybody's mama told them when you were little, you're 1 in a million. Now that sometimes that was a good thing when you brought home an A on your report card. Not so good when you broke your brother's radio. Okay, so, but you are 1 in a million. You've got about 3,000 cases a year in the United States. And there's about 3,000, the population of the United States is about 325 million. It's roughly 3,000 cases a year. So you are literally a 1 in a million. So when you go home today, you're luckier than you think, maybe. Okay. Now, again, one of the beauties of this kind of a survivorship event, talk to the people around you. Some of them are going to be survivors. And again, so I'm going to go back here and some of the pictures put up here. So now I'm going to talk about the malignant tumors a little bit and what you do with them. And these are some patients who I've had before they gave me permission to put their pictures up there. And this is the devil we're looking at. So let's talk about the carcinoid tumors first. I suspect there's some people in the audience who have had the carcinoid tumor. It's about 40% of tumors from the appendix. It's usually in the distal tip of the appendix, so it rarely causes obstruction. Once it spreads, these tumors can produce some hormones, which leads to something called a carcinoid syndrome. Tumor markers we can use, and one of the devilish things about these types of tumors is they're known to have brothers and sisters present at the same time. Not metastases, but second primary tumors. They're annoyingly common, and you have to look for them. This disease does not actually lead to pseudomyxoma syndromes. Most of them are really little. Most of them are cured with a simple appendectomy. Most of the time you'll catch them incidentally. About a quarter of them will have nodal metastases to the lymph nodes along the colon. About 10% will have distant metastases to other places. You can do cytoreductive surgery for these patients, but the HIPEC is not really helpful. You'll frequently see them in stage 4. When you actually see the tumor, they're very scar-like and sclerotic, so they're difficult to take out sometimes. These are not the best candidates they're good candidates for cytoreductive surgery, not good candidates for HIPEC. And the good news is the systemic therapy has actually improved substantially. And now I'm going to shift gears a little bit and talk about some of the cancers that give rise to the pseudomyxoma programs. Everybody wants to know about famous people who have had this disease, so I couldn't help but put a couple of pictures in there. Audrey Hepburn, can't pass from this, and Stuart Scott, who's, if you're into sports, you probably know who he was. Both of them face this disease at different ages. Again, this is a rare disease, and what do I usually tell people, other surgeons, and again, I give this talk mostly to other surgeons and people who are going to be looking at this disease. If you find it, what do? Explore, find out, take out the appendix if you want to, and then stop, put your pencils down, and send the patient to somebody who does a lot of this. If you don't do a lot of this, you probably shouldn't do any of it. This is a disease that needs to be treated by people, and I'll show you the learning curves for this shortly. Again, there's a variety of histologies, and the bottom line here is probably the most important. Most of the time, since there's no screening program, most of the patients are going to be found with peritoneal metastases, and it's already spread. There's how many we've got. We use tumor markers a lot. Even these have got second primary tumors. If you do look at that colonoscopy study I showed you before, close to 40% of patients when they're found to have an appendiceal cancer are going to have other polyps or an additional cancer in the colon somewhere. So it's not at all unusual to find patients who have got a cancer of the appendix, and oh, by the way, they got something else too. And that's something, if you're not the doctor who's looking at this, you want to be looking at this, because that's something you always want to be screened for. The prognosis is closely related to grade, and I'm going to take you through the original research data. If you find this early, before it ruptures, again, taking out the appendix is all you need. If it spreads to some lymph nodes or it's high grade, taking out the right colon usually goes with it. And again, what about the pathologic descriptors? Everybody wants to know about the pathology report. What does the microscopic analysis show? And I'm going to show you what the actual picture of this tumor looks like in just a second. There's different tumor systems in terms of how you grade it. Basically, you can grade it into low grade and high grade. There's also an intermediate grade, and the person who wrote about this originally is Bridget Ronette, who who worked with Sugar Baker at Johns Hopkins. The original system, which was came out almost 30 years ago, my goodness, was a 3-tier system. We use a 2-tier system because it's a lot easier to use. Memorial Sloan Kettering, and we use basically the same system. There's some interesting signet ring cells are bad actors. You may have heard of some of those. And if you don't have them, good. You don't want to meet them in person. WHO fascicle. Who? No, not who. That's World Health Organization. So the World Health Organization realized that there's problems with all the different pathologic staging systems. There was a international meeting to come up with a standardized system. They wrote a lovely fascicle. It's interesting reading. Nobody uses it. So it could have solved the problem, but did not. So what do these things actually look like? This is a low-grade cancer of the appendix, sometimes called used to be called a DPAM tumor, disseminated peritoneal adenomyocynosis. I know you're not histologists, but I'm going to take you through the basics real quick. What you see out here, this is an ocean of mucin. What you see in here is fibrous tissue underneath the cells, and the only cells that are producing mucin is a little line right there. That's it. Those cells lining those cysts are what produces the mucin, which can accumulate in the abdomen. It's not a lot of cells. It also tells you that they're really productive little buggers. They tend to produce a lot of mucin. If we could shut that down, it would be a whole lot easier. Although most people don't have problems, most people don't die of the mucin accumulation. It's the cells that produce the mucin. So underneath it, this is all basically scar. The body's trying to wall it off. So this is a low-grade tumor. This is more of an intermediate grade tumor. What you see here is there's a little bit less scar. There's still mucin. And now the cells, and it's harder to see, are moving through that little stroma back there, moving into the soft tissue. And this is a really high grade tumor. What you see here is the same sort of thing like the intermediate grade. And now you've got cancer cells which are floating in the mucin, looking for places to land and cause more trouble. So if you look at them under the microscope, this is what you see. That's some of the differences between a low grade and a high-grade tumor, and why you can imagine with all these malignant cells floating around here looking for places that cause more trouble, why the high-grade is so much more serious a prognosis. And again, this is difficult to see from the back of the room, but what you're seeing here is differences in outcome based on the different types of cancer of the appendix. And these are from 3 different institutions. This is a SEER database, which is a national data set. This is our own data at Wake Forest. This is one from the University of Pittsburgh. They're all showing you basically the same thing, which is different types of cancer have got different prognosis based on either what the subtypes are, what the grade are, G1, low grade, intermediate, and high grade. It also tells you that getting an expert pathologist to look at the tissue when you're initially diagnosed is crucial. That's really important. Now, not all of these cancers behave the same way. They have the same diagnosis, but they behave different ways. So one of the things that occurred to me 15 years ago or so is how can we pick out who's different? So I know most of you in the audience have not had a science class in some time. You're about to get one. So what I started to look at, one of the tools we have now is to look at all the genes in the cells. We're all made of cells, right? In the cells, in every one of the cells, there's a copy of the DNA. And the DNA coding or telling the cell to do the wrong thing, like grow and divide and spread, something has gone wrong. So let's see if we can figure that out. So what did I do? And this, what you're going to see is the first genomic analysis for cancer of the appendix that was ever done anywhere. And we did it here. And oh, by the way, some of the funding for that came from the ACPMP people. So again, I will thank you now, once again, for a grant you gave me a few years ago. I actually did something with it. That's good. Yeah. So what do? We have a lot of tissue here, and there's somebody, if you go outside, you'll learn about ways that you can get tissue to researchers. I can volunteer for that. It's another important thing. Whenever we operate on anybody, we ask them to participate in what we call a tumor bank, where we collect tissue and their medical records. We put all that together, and out of that, we harvested patients who had cancer of the appendix. We did something called an Affymetrix gene array scanner. Good news, there will be no quiz on what that is, okay? But what it does is it looks at all the genes that are active in the cells, and what did we learn from that? So this is the word of the day. For those of you who do crossword puzzles, the word of the day is dendrogram. What the heck is that? A dendrogram is what we see up here. We divide all the different patients into different types. The red bar up here tells you where the appendiceal cancers are. We compared it to the blue bar up here is colon cancer. And you can see there's some patterns in here in something called a heat map. So for each one of the genes we looked at is one of the little boxes in there. And you can pick out patterns. Appendiceal cancer, look, they got the oceans here, the blocks here. They're totally different than this pattern here. And what we find is a couple of things you'll find pretty quickly. First of all, you can pick out who's going to do well based on the genes. Remarkably well. It's actually better than pathology. Now, that doesn't mean you don't need a pathologist. It does mean you need both. But the next step is going to be looking at that. The other thing that I learned back here, and you're going to be hearing me harp on this, appendiceal cancer is not the same as colon cancer. And many of my colleagues in oncology have yet to learn that lesson. Now, just in case I haven't made my point, I'm going to go down. We redid the analysis, and here's the word of the day again, dendrogram. So here's a new dendrogram looking at the same thing, and these are different curves, looking at the genes that are active in the tumor. Low-risk genes, the green line up here. High-risk genes, right there. These are 5-year survival rates. Boy, there's a lot of room here. Almost nobody died with these low-grade favorable genetic lesions. Now, all these patients had surgery, to be fair. But look at the differences in here. You look at 60, 70% differences in survival rate. And that's something that can be predicted, which is beyond what the pathologist is going to be able to tell you. Just in case you don't believe me, other people have done something relatively similar. So what has come up is something new called precision medicine, which is led by NGS, next generation sequencing. And that means you take the DNA which are in the cancer cells, pick them apart, and see which genes are active in each patient's particular tumor. And this is a group called the Foundation, what's the name of the assay, looked at 700 patients with cancer of the appendix. That's a big series, biggest one ever. Unfortunately, they don't have outcome data for any of these people because it's a pathology department. People send them this, they do the analysis, send them back. There's no follow-up for any of what they're doing. They broke it into 5 different types. They can tell you the names of the different genes that are most active. There will be no quiz on what they are. GNAS, KRAS, there's a number of them there, P53, and which is which. And then what did they learn when they looked at this? Because they compared their large data set to patients who have cancer of the appendix. What did they learn? The mutation profiles are not the same as cancer of the colon, or cancer of the appendix is not the same disease as cancer of the colon. Another company, their main competitor, did basically the same thing. And they looked at this, they added some other things here. They looked at something called MSI, or microsatellite instability, total mutational burden, which is the number of mutations in the genes. These appendiceal cancers tend to have relatively few mutations in them. And those two things combined with this PD-L1 here, which tells you this is a marker to tell you if you're going to respond to immunotherapy. It's going to tell you that these tumors are highly unlikely to respond to a lot of the new immunotherapies. That is bad news because there was a lot of advances for lung cancer, renal cancer, a lot of other tumor types. Unfortunately, for cancer of the appendix, it's not going to work. And they reached my favorite conclusion is cancer of the appendix is not the same sort of thing. This is another one. We went further. Beyond looking at the genes that were on that chip, I then looked at every gene in the entire body, in the whole genome, what makes all of us up, and look at all the mutations in there. We looked at a lot of these patients. We found this KRAS mutation is found in 90%. And before you get excited, find an anti-KRAS gene. It's also very common in other tumor types of the GI tract. So it's actually a hard one to target. We have a low mutational burden. And once again, cancer of the appendix is a different disease. Okay, I'm now going to get off the soapbox because I think you've already seen that. And I can also tell you what the different mutations are. There's different types of mutations in cells. Some of them change proteins that are in the cell. Some of them don't. Some of them change the way the cells regulate each other. Some of them don't. Some of them stop things from being made. Some of them don't. But this is how we figured out What are the genes? What are the mutation patterns? So we're actually learning, we've got the footprint in the cells of what the DNA changes are in the cancer of the appendix, which is something which is never done before. It also tells you that if you look at this, this is another survival curve. So this is who's alive 5, 10 years later. But what's important, looking at all this genetic data that we pulled together. The most important thing is still the histologic grade. The other things that count is how completely you get the tumor cleaned out. Chemotherapy doesn't seem to make all that much difference. And this genetic subtype is a 3-to-1 risk factor if you have a favorable genetic profile or you don't. So, what can I say about this? Genetics are here to stay. What we've learned from this next generation sequencing and the precision medicine efforts in terms of research which has been done for cancer of the appendix is that although there's a great amount of excitement for other different tumor types, it is unlikely to help more than 2% of the people or the patients who are sitting amongst us today. So hopefully you don't need it. If you do need it, this is not where the answers are going to come from. And this is a report I got from one of my patients. And basically what it says is we did this gene analysis. We looked at 700 different genes, and we find nothing that's going to help you. For that, they charged them $4,000. So genetics are here to stay. My favorite line, I'm not even going to say it anymore. This is a different disease than we treat. Obviously, if the genes, the underpinning, the way it looks under the microscope are different, you cannot treat it the same way we do as colon cancer. All the chemotherapy regimens for cancer of the appendix are based on cancer of the colon. That is not the right approach. So obviously we need some new approaches to what we're learning, and at least that's one of the points we can make already. We can pick who's going to best respond potentially to systemic therapy, who's going to survive. And what I've been looking for is some genetic signatures which will tell us who not to operate on. Some patients' prognosis is so bad we can spare them the rigors of the big operation I'm going to be talking about in a minute. Now, cytoreductive surgery and HIPEC, which is something that most of you have heard of or experienced, is done for a bunch of different types of tumors. This is 10-year survival rate. This is a paper I wrote on our first 1,000 cases. And at the time I wrote this was the largest experience report on planet Earth which had ever been published. And this came out 5 years ago, so we've done plenty more since then. The curve at the top, in terms of the best outcome curves, this is cancer of the appendix. It's been approved for cancer of the ovary, which is down here, buried in the muck. You can't see it. We use it for mesothelioma. It's probably the treatment of choice. You can use it for colon cancer, occasionally for gastric cancer, for other tumors. Cancer of the appendix is clearly the best treatment for this. So what are the real treatment options for cancer of the appendix? Systemic chemotherapy. I'll talk more about that in a minute. Radiation therapy. Don't do it. Peritoneal venous shunts. This was an amazing thing. We used to use these for ascites. It's actually a little tube that shunts fluid from the peritoneum or the abdomen into the veins. Obviously, if you can do that if you just have ascites from liver failure, renal failure, something like that, and then sometimes it'll help the fluid go down in the abdomen. If you do that with mucin, it becomes an embolism. So people have died of people trying this. These are uninformed doctors on innocent patients who did not do well. So that you never do. So what do you really do? Conventional surgery, which is go in there and get out what you can. That's easy. I don't recommend that. Cytoreductive surgery, which is go out and get out as much as you can, including all the bulk disease. That I can recommend. And then cytoreductive surgery with some sort of an intraperitoneal adjuvant like HIPEC, and for those patients who are beyond anything else we can do, are not strong enough to do this, hospice is certainly a good thing to do for some patients. So let's talk about chemotherapy for cancer of the appendix. This is a paper I wrote with the MD Anderson group. The response rate to systemic chemotherapy was a thrilling 8%. 8%. That means 92% of the time it didn't do much. Now, we can tell you who it works on. For low-grade tumors, it essentially never works, so I don't recommend it for that at all. For high-grade tumors, there's definitely a role, and for patients with high-grade disease, it'll increase their survival rates pretty significantly. 15-month difference in survival, I think it's worthwhile for high-grade cancers. For low-grade cancers, I certainly wouldn't bother. Treatment for palliation is fine, and if you're going to treat patients who've got this disease, the goal of treatment is just to hold the tumor steady. Why? Because the mucin never shrinks. There are ways to get rid of it, and I'll talk about that at the end of the talk, but the treatment never needs. So the usual treatment guys, if you have a colon cancer and treat it, you want the metastases to shrink and go away. If you got a gastric cancer, all cancers, most of the cancer you're going to treat them to shrink them and make them go away. You can't do these with pseudomyxoma. It doesn't work. And I've been seeing time and time again medical oncologists who are trying to do the right thing, trying to treat this disease like cancer of the colon. Bad plan. Now, if you go to Memorial Sloan Kettering, which is a otherwise totally terrific cancer center, this is a series they put out a number of years ago looking at surgery alone. And although they gave some patients treatment, their mortality rate here was 4%, morbidity was 16%, which is a clear understatement. Cure was uncommon is what they learned. Now, this was patients, they did not have a HIPEC. They just did the easy stuff. They went in there and took out the low-hanging fruit. Things were relatively easy to remove. Their long-term disease-free survival rate was 12%. 12%. That is a low number, just trying to pick out the easy stuff. And most of the patients they operated on more than 2 times. This is what their curve looked like. Some of the patients were long-term survivors. Most of them, particularly with high grade, they did relatively poorly. So this is what you get with basically surgery alone. And the surgeons at Sloan Kettering, these are good surgeons, okay? I've got nothing bad to say about them. The Mayo Clinic did an interesting study. Now, this goes way back to the last century. And looking at the audience, I know there were a few of you who are alive, who are still with us. Most of you were born since then, right? And they looked at patients who had the same pseudomyxoma, and they treated them either with surgery or surgery with some sort of intraperitoneal adjuvant, which was either fluorouracil, which was crude, or some radioactive phosphorus. And what did they find? At 5 years, if you use something extra in the abdomen, the survival rate went up 20% or 40% for disease-free survival. That's pretty significant. So doing something beyond just surgery is probably a good idea. So what is cytoreductive surgery and hyperthermic intraperitoneal chemotherapy? Basically, the premise is you have a disease which is spread through the peritoneal cavity. The rate of these tumors spreading to other organs like the lungs or bones or brain is very, very low. You're looking at a 2% event. Very few patients are going to have tumors spread that way. So you have a peritoneal disease, treat it with a peritoneal process, aggressive in the abdomen. Treat the patients, if you're going to give some sort of treatment into the abdomen, you want to give it when all the adhesions or scars, lights, and everything's wide open, and the chemotherapy or the drugs that we're giving into the abdomen can actually hit the target. That's important. Hit it when there's minimal residual disease. HIPEC, if these postoperative things are more complicated. We usually deliver the chemotherapy at elevated temperature. Why? Because the chemotherapy works better if you elevate the temperature a little bit. So usually 104, 105, 106 degrees, something like that. And the optimal temperature, I will tell you, for this has not been defined. Elevated temperature, yes. How much? We can have a long debate on that. Frankly, there are symposia which are held on that. There'll be one in February, and there will be long debates about what you should do about that, what the temperature is. Having said that, elevate the temperature is fine. It also warms up the patient during the procedure. And the other thing, that the real advantage here is that the amount of drug you can deliver to the target tissue, if you literally pour it on the cells in the peritoneal cavity, is substantially better than you can get with even the most aggressive IV dosing. What do you mean? So this is the one slide I put in on pharmacology. Forgive me, usually I say pharmacology, people's eyes will glaze over, they start drifting off to sleep. So the real number here is PE to plasma, peritoneal to plasma ratio. Some people have heard of a blood-brain barrier. I don't know if somebody's heard of that. And basically, it's something that keeps drugs from getting out of the bloodstream into the brain. It's the way nature protects us. There's also a peritoneal barrier, which works the same way. Now, I'm not sure why it's there, to be honest. I frankly wish it wasn't, because if it wasn't there, the chemotherapy you give by vein would work better. But it's something we have to deal with. If you pour something into the peritoneum, as opposed to giving it IV, the advantage for mitomycin is 75 to 1. For oxaliplatin, 25 to 1. Taxol, floxuridine, some of these other things, 1,000, 2,000 to 1. So you can deliver a lot more drug to the target than you could ever get with even the most aggressive IV chemotherapy dosing. So intracavitary, the intraperitoneal treatment's got some substantial advantages. So how do we know who to operate on? Who do I offer this operation to? Well, I'm just talking about appendiceal disease. So we're going to do this. Patients have got to have disease has got to be confirmed. We have to know what we're operating on. The primary tumor's got to be resectable. If you can't get the primary tumor out, removing the metastases is not going to help you a lot. Similarly, the metastases have got to be resectable. To take out the primary tumor, if you leave a lot of the metastases there, you're not going to achieve anything. Oh, there we go. We don't have disease outside the abdominal cavity. Cytoreductive surgery and HIPEC does nothing outside the abdominal cavity. There's not enough of chemotherapy that goes through the bloodstream. So if there's a tumor in the lung, if there's a tumor in the bone, if there's tumors someplace else outside the abdominal cavity, it does nothing. So those patients are not going to be people we're going to be able to help. And you have to be medically fit to have a big operation. Cardiac status, pulmonary status, nutritional status, performance status, which means what kind of shape are you in. And something I added for this talk is this one, which is emotional status. You have to be mentally prepared to do this. These operations are substantial challenges, and I'm seeing some heads nodding. These are challenges. These operations will frequently bring Marine recruits to their knees. Okay, this is tough stuff. Before surgery, we'll have you see anesthesia. We usually get a bowel prep. We use quality of life evaluations for everybody. Everybody gets IV antibiotics. Deep DVT, deep venous thrombosis. If you're going to take the spleen out, we give some vaccines to get ready for this. Sometimes we'll put stents in the ureters to protect them. We have urologists help us for these operations, cardiac evaluation, nutritional support if they're not in good shape ahead of time. So getting ready for one of these big operations is a big deal, okay? You're looking at a substantial challenge any way you put it. To the patient for sure, to the surgeon, to the anesthesia team, to everybody who's working for folks who've got this disease. So what do you do? What are the goals? What are the rules of engagement here? So after you get everybody ready, exploration and resection. Most of the time this is done through a big midline cut down the middle. That's the way we do virtually all of these. Occasionally find somebody really early. Sometimes you can do it with a laparoscope, not too often. So what do you want to do? The goal is complete cytoreduction. You have to get everything that you can see or feel out if it's at all feasible. The intraperitoneal chemotherapy is really helpful, but it only penetrates the tissue 2 to 5 millimeters. 2 to 5 millimeters, that's this big. It's very little. So if you got a tumor which is this thick, you're not taking out, all you're going to do is sand off the surface. That's not going to do anything. And what's more, if the cells that you don't remove are exposed to this drug, those cells are devils. They are smart. They will learn how to be resistant to it. So all of a sudden now you got a resistant tumor, now you got an even worse problem. So you've got to go, the goal is to get in there and get everything out. Obviously, you want to remove all the gross diseases as priority one, spare as many organs as you can, and avoid colostomies and ileostomies if possible. The perfusion, when you give it, you want to perfuse the entire peritoneal cavity evenly, get the drug and the temperature evenly moved around. There's different ways to deliver it. The temperature is usually between 40 and 42 degrees. In the chemotherapy, we use a 2-hour perfusion run at Wake Forest, which is one of the longest perfusion runs in the business. And interestingly, most of the centers from Europe are moving away from the 30 minutes and coming back to our studies, which just makes me feel better. This is what the actual pump looks like, and there's different types of pumps, and I'm not going to tell you one's better than the other. And here's 41 degrees. This is what the temperature going in, temperature coming out. We monitor the patient, the fluid going in, the fluid coming out, the patient's core temperature, the patient's peripheral temperature, the patient's urine temperature. So we keep an eye on everybody, and the patients, when you're having these operations, we are looking after you close, and that's required. And this is what one of the drugs can look like when we actually deliver it into a pump. Now, how do you grade these things? Many of you have probably heard of the PCI score if you've done a lot of reading of the peritoneal cancer, peritoneal carcinomatosis index. This is something Paul Sugarbaker came up with, one of his best contributions, I think, to the field, if you don't mind me saying so. And he breaks the abdomen in a really cumbersome system. This is something he didn't do right. Plan for the scoring system, good. How he did it, not so hot. 13 breaks the abdomen into 13 zones. They're all rated 0 to 3, so you have a score between 0 and 39. And then that's what's there when you start. And then we grade how much is left when you're done. And there's 2 ways to do this. There's a completeness of cytoreduction score, which Paul put out. And then he says if it's thicker than 2.5 millimeters, that's going to say a little bit left, a lot left, whole bunch left. I use a different system. This comes out of the International Staging System, which is the AGCC manual. R, which stands for residual. R0, you never have no residual, always some cells left. So the best you can get is really an R1 where there's something microscopic. R2 means there's gross residual, which is broken down to A, B, and C, less than 5 millimeters, 5 to 20 millimeters, more than 20 millimeters. What we want to get is R1 or R2A. If you've got more than that, sometimes we can help you to avoid ascites and recurrences, but you're not going to be a long-term survivor. Gross picture. Look away if you don't want to. So if you ever wanted to see the devil, that's the devil. What are you looking at? This is the cecum, part of the colon. This is the appendix right here. This little thing, this little clamp is around the neck of the appendix. This is what the appendix should look like. A little thing like that. The actual name of the appendix is the vermiform appendix. Vermiform, again, for you Latin scholars, and I know you're out there, vermiform means worm-like, which means the appendix usually looks like a worm, and it's about that big. Obviously, you got something really big right here. This is where the tumor is. The tumor is ruptured, and this mucin is coming right out of there. And thus, there's cells in there which have landed in other places, and that's what we look like. So when we get in there, that's what do the primary tumors look like? That's what they look like. The average general surgeon in practice will remove 2 of these in a career. I'm going to say that again. The average surgeon in practice will remove 2 in a career. Most surgeons operate for 30, 35 years. Again, so is it an unusual tumor? Yes. Most surgeons have never encountered a case. That also tells you they don't know what to do with it when they find one. So I'm going to take you through our experience with this from 1992 to 2019. The first case here was actually done December 30th, 1991, but that was not an appendix case. So the first appendix case was from 1992. We're using the same technique, and there's some series where we've written about this. And this is 859 out of about 1,600 HIPECs, which we've done here to date. So first thing is the resection score. The top line, now this survival curve, 5 years, 10 years, 12 years is as far as we went with this data. There are some people here in the room who have survived more than 12 years, I am proud to say. These are some of our star patients. Congratulations. Thank you for making us look good. So what are the actual data here? So let's go with 10-year survival rates. Usually when people are talking about cancers, we talk about 5-year survival rates. For this, if you do these operations, you get things cleared out, we can realistically talk about 10-year survival rates, which are somewhere in the 70 to 80% range. So if I can get everything cleared out, most of the patients are going to be 10-year survivors. If you have a little bit left, it's going to be 40 or 50%. If you got a lot left, your chance of making 10 years gets to be relatively modest. So it's important to be able to get this out. The biggest determinant of how you get this out, I'm going to come up with, show you in a couple of minutes. This goes to histology. Now, this only goes up to 60 months. This is the low grade of the DPAM tumor, intermediate grades. And why do at Wake Forest we classify the intermediate grades with the low grades? This is why. Because they do the same. Outcomes are the same. So why stratify? Because the truth is pathologists have a heck of a time figuring out what an intermediate grade is. They'll tell you what low grade is, no problem there. They'll tell you what high grade is, no problem there. And intermediate, yeah, you get 3 pathologists, you get 5 opinions. That's just the way this goes. So the intermediate grade is just you use the 2-tier system, that's why. What about lymph nodes? Now, if the tumor spread to lymph nodes, this is a paper I wrote with Dr. Votanopoulos a couple of years ago. I think the first one that showed this. So this is low grade, best outcomes over here, low grade node negative. Again, really great long-term survival rates. High grade node negative is this pink line here. Even if you're low grade, if you've got positive lymph nodes with a low grade tumor, which is only about 3 to 5% of the cases, or even worse with a high grade tumor, the outcomes are not as good. So even though the tumor spread to other places, whether it's spread to lymph nodes is important. This is one of my favorite slides because this is an original work we did here at Wake Forest. Look at the performance status. So what kind of shape are you in? So we use something called the ECOG performance score. And when all of you came in, you were all scored. And this is where low score wins. 0 means you're in perfect shape, no problem. 1 means you have minor symptoms. 2 is major symptoms. You can still take care of yourself. 3, you have trouble taking care of yourself. 4, we don't even treat. Those are people who are basically bedfast. So if you come to see us and you're in good shape, your long-term survival rate is terrific. Once you've got symptoms, your outcomes are far worse. And if you've got severe symptoms, our chance of being able to salvage you and get you far down the road is not that great. And the reason you're having symptoms is you're going to have a whole lot of tumor in there. It also tells you that we want to bring these patients to surgery in the best shape we can get you in. Sometimes we can tune you up, we can give you some nutrition, we can help get things good, we can take care of any heart problems, lung problems you've got. So we want to bring the patients to the operation in the best shape they can be in. This goes back to that series of 1,000 cases we did. Now this goes back to show you the learning curve. How long does it take to get to be good at this? And the answer I found somewhat depressing, because the answer is a long time. So these are survival curves, and I broke the experience into the first 200 cases and all the other first 200, 400, 600, 600, 800, 800, 1,000, and 5 pieces. Oh, there we go, wrong way. And this curve at the bottom, in terms of the worst outcome, this is the first 200 patients. Learning curve is long. You need to do a lot of cases to be good at this. So what do we learn from all this data so far? Most important thing is histologic grade, depending on how much disease you present with and how completely you can get it out, turns out to be important. Your performance status, what kind of shape are you when you come to the operation? Also important. You'll notice the words are getting smaller as they go. That's relative value in terms of how important they are to the patient getting through there. Nodal status. Do you have complications after surgery that can decrease things? And where is your surgeon on the rate of the learning curve? Now that's our data from Wake Forest. So just to go through it, you say you're not satisfied. Okay, let me show you the data that's international from a number of centers. This is a study that went over 20 years, and it was 16 centers. We participated in it, and we were one of the biggest centers, 15% of the data, 2%, 24% complication rates, and what did they find here? So these are survival curves. 60, this is in months this time, not in years. So this is 60 months, which is 5 years, 120 months, 10 years, 15 years, and beyond. So this is the overall survival if you get everything cleared out. If you get everything cleared out and you do things the way that we do it, or most other big centers do this, I find this very reassuring that if you do the surgery the same way and you follow the same principles, you get the same results. This isn't the result of one really great surgeon doing everything right all the time. If you follow the principles and you do the surgery properly, you evaluate the patients properly, do the right thing, you'll get the same results, which means if we educate other doctors in terms of how to do this, this room will be even more full in years to come, which is what we're looking at. It also shows this the same thing, looking at the same, if you get complete cytoreduction here, if you get everything cleared out, R0, R1, these patients are going to be looking very good. You've got long-term survival rates, 60, 70, 80% to 10 years and beyond. It also tells you that survival beyond 5 years, 10 years, 15 years is possible. I'll tell you that we've got data going back now getting close to 25 years. Some of these patients are cured. Now, cured is a funny word to oncologists. They don't like to use that word because this is a funny tumor. This tumor can come back. I've seen it come back 20 years later after a disease-free interval that long. So yeah, it's hard to say cured. But some of these patients are cured. Not enough, I'll tell you, but a lot of them are going to be. And again, if you look at grade, low grade and intermediate grade look about the same. High grade don't do as well. So what did we learn? We learned from the multi-center database everything that we found here on an international basis. So that's what the operation is, but there is a price to be paid for this intervention. It is a dear price, and I'm not talking about dollars now. I mean a personal price. Mortality rate, depending on where you get it done, is somewhere between 0 and 12%. People are going to die. If you go into a place that's got a 12% mortality, you might want to reconsider where you're going. That's way too high. The number ought to be in somewhere in the 1 to 3% range, which is actually pretty similar to other major cancer operations. The morbidity, depending on how honest you are, or complication rate, is somewhere between 12 and 56%. So getting through these operations is rough. Again, anybody who's in here knows this is not a walk in the park. And I will also tell you there are people in this audience who have gone through some reasonably horrendous complications, have made it through and have done well. But that's part of what we have to do. About 10% of the people have to return to surgery or drainage procedures. The colostomy rate, depending on who's doing it, is between 10 and 50%. Our rate is about 15% here, and we've got one of the lowest rates around. There are some people who book colostomies on people who have these operations all the time. I don't think that's a good idea. The rates tend to be decreasing over time in terms of complication rates. Currently, less than half of the patients we operate on are going to the ICU anymore. That's not the way it used to be. Now, the other thing we're looking at is long-term quality of life. And Dr. McClellan will talk to you about that. And although he looks like a modest soul, the truth is he knows he made a lot of this happen. So we have done the largest quality of life study on earth for this disease and for these procedures. We've got some of these studies which are ongoing. I'll tell you about some of those and some of the things that we've learned here just by summarizing. There is significant morbidity. It takes a while to get over this. Your physical functioning after these big operations is frequently not back to full speed even 3 months later. Usually get back to baseline about 6 months. And here's a couple of things that I expect to get some heads nodding. One of the things we found in these things, which are some problems that most people don't think about and don't make it into most oncology scoring systems, sleep disturbances are a big problem. I mean, for the patients we look after here, it's probably close to 15 to 20% of patients have got really significant sleep problems. Something nobody ever thought about until we started looking at quality of life. And late depressive symptoms, and not just for people who recurred, is rough. And some of this is post-traumatic, and Dr. McClellan's going to talk to you more about that in a minute. We use some of these fancy called instruments, or basically, if you're Dr. McClellan, these are instruments which are, if you are me or you, they're going to look like a questionnaire. Okay, but that's what we thought. This is how we measure quality of life. And this is a whole bunch of different ways that we look at quality of life. And then you've got 5 different time points: before surgery, 3 months, 6 months, 12 months, 24 months later. And what do we find? A couple of things. By 6 months, you're usually back to where you were. But it takes a good 3 to 6 months to get over one of these. And get to the next slide. Pain inventory, you're going to have some increased pain. Things may hurt for a while. Just getting over the operation for some months. Tends to get back to where it is. And actually, if you look at the curves down here, which is actually the blue one is the money curve here, it tends to be lower at 6 months, and they're pretty much back to baseline by a year. And this is one of my favorite slides. Tough to read. Basically, what you're looking at here, DESD, this is a scoring system. When we look at quality of life, we look at depression standards. Who's depressed? So before surgery, right here, you got a lot of people who are relatively depressed. By 6 months later, the rate of depression is down by 40%. Now, one of the things I love to tell my friends in psychiatry is that a HIPEC is a better antidepressant than Paxil. So if you make it through, this is actually pretty good for your mental status. All right, so what else can we learn here? HIPEC prone for cancer, the appendix. We also learned that quality of life does not immediately impact things. Even if you have a recurrence you can see in a CAT scan, that usually doesn't give you symptoms for some months or years, which means you can follow people who've got some of these recurrences for years. You don't have to rush back to the operating room all the time. Quality of life tends to be maintained over the long haul. Physical defects can impact quality of life, which is why exercise is important after surgery. Kate's going to talk about that a little bit later. Sleep disturbances are problems. Dr. Duckworth will talk to you about that later. So why did we pick the topics we talked about? Because we found them in our quality of life studies. Our patients told us these are things we have to be looking after. So I'm glad you're here, and I'm glad you hear this. And it's something we find out. Depression is a tougher nut to crack, but you're going to hear from a couple of people who can help you out with that. The next question we ask, and this is more cutting-edge quality of life research, is what about the people in the room who are not the patients but care deeply about them, or the caregivers, the families? This is a very, very difficult operation to get through on your own. Very tough. This isn't like having a knee arthroscopy, which is tough enough. This is a life-changing, life-challenging event. You need to have a support team. And if you check out some of the T-shirts around the room, you'll see you got a lot of support teams here, which is great. But what's the effect on that? We actually went back and looked. This is a paper I'm going to be presenting in about 2 months. Since I'm going to be presenting it, I can't actually tell you what the results are. But this is a paper I did with Dr. Duckworth and Dr. McClellan looking at the impact on the patients' families and the support group. So this will be presented at a very snooty surgical association, which was silly enough to let me in. That's going to be in December. Probably the paper I'd expect to be coming out sometime early next year. Now, I've not talked to you at all about prospective randomized trials. And now I'm going to take you through the only ones there are. The first study was a study which was done at the National Cancer Institute. This is the design for the trial right here. And it was a prospective randomized trial which was going to compare patients who had cytoreductive surgery to cytoreductive surgery in HIPEC. They couldn't get it done. Now, at the National Cancer Institute, if you go to have your surgery there, it's free. It is paid for by our tax dollars. That's where the money comes from. Giving their surgery away for free, they still couldn't fill us trial. So I figured, okay, we can't do this trial. Let's do a different trial. I built a different beast here. So there's only been one prospective randomized trial. I'm going to take you to the world's literature on prospective randomized trials for cancer of the appendix, because there's only one study, and we did it. So this is a study that I designed, and University of Pittsburgh and MD Anderson worked with me to help this study move forward. Multi-center trial. We randomized 133 patients with cancer of the appendix, some of whom are in the audience with you. No, I will not point them out. And Joyce helped me do this, and this was a lot of her job. And she helped a lot of patients through this study for a lot of years, to be honest. We randomized, 133 could only evaluate 124. This is the only prospective randomized trial for cancer of the appendix was ever done for any stage at any time ever. Study was simple. Basically, everybody had cancer of the appendix. They had cytoreduction surgery and HIPEC, and we compared two different drugs. We compared the drug called mitomycin, which has been the standard for many, many years, to oxaliplatin, which is a new drug, which is much more active. And what did we find? 136 patients, we randomized them. The average age was about 54, 55. It took us 6 years to fill this study at 3 centers. When I started out, most people told me a randomized trial for cancer of the appendix was impossible. This was funded through philanthropy and basically force of will, I think, is how I got this done. 3/4 of the patients were low grade. 80% of the patients came from Wake Forest. What did we find? So the first one we looked at the white cell counts. Big difference here, and what this tells you is that mitomycin is a lot more immunosuppressive. It tends to lower your white count a lot more than oxaliplatin does. There's some subtle differences in platelet count. He doesn't do anything to the red count. No differences in platelet toxicity. The white count toxicity was a little bit higher with mitomycin. And somewhere about 20% of the patients, we end up giving drugs to bring their white count back up. And this is all very interesting, but that's not what most people want to know. What most people want to know is this slide, is there a difference in survival if you use the two different drugs? And the answer is no. The two drugs work the same. They both work, as far as I know, but they all seem to work equally well. There's no difference in progression-free survival or overall survival out at 5 years. This study is now out here somewhere closer to 7 years, and there's still no difference between the two groups. It also tells you that in a prospective randomized trial, which is the blue chip data that all oncologists want to see, the outcome data out at 5 years is, again, the 70% range in terms of long-term survival rates. So this isn't just surgeons picking their best cases and doing the best thing. This is true prospective randomized data. It also confirmed that low grade do better than high grade, complete resections do better, and there's no difference between stratified groups if you stratify them for whether they're completely resected, not completely resected, no positive, no negative. There's no difference between the drugs. There is a difference, however, in the quality of life. So the TOI is one of the measures we use to look at how patients are doing after surgery. And for the first 6 months, patients who are perfused with oxaliplatin seem to have a better quality of life in terms of getting through their day-to-day activities and fewer side effects. So this paper was presented a few months ago. This paper was accepted for publication in the Annals of Surgical Oncology 2 weeks ago. So I'm giving you, I think, relatively state-of-the-art stuff. So I'm getting near the end of my allotted time, although I would like to go on for about another 6 hours or so. So first thing I want to say is trials, randomized trials for cancer of the appendix are possible. They can be done. We did it, okay? We did it with the help of patients who were brave enough to sign up for randomized trials when they came in at the most stressful possible time. So being part of randomized trials is important. We learned that white cell toxicity is higher, platelet counts a little bit the same, quality of life is a little bit better with oxaliplatin. What about, can you do this operation again? Iterative or repeat procedures. If you reset the clock, if you have to go back and operate on somebody again, this is the second survival curve here. It's actually about the same as the first time. So if you can go back, if you have to operate on somebody a second time to get things cleared out, using the same rules of engagement, the long-term survival rates are about the same. If you choose your patient selection well, and we've done second and third HIPECs. We've had one patient we've done a fourth one on. So again, you can repeat these procedures. Now, this will be hard to read in the back of the room, and I hope you'll be able to pick this out later. What are the prospective randomized trials which are currently available for cancer of the appendix in the United States? I can fit them all on one slide. That is pathetic. That is nowhere near what we need to have for people in this room and beyond. You can't see this. A couple of these I'm going to highlight. Some of them are drug studies which are only available at a couple of spots. We've got two here which I'm going to highlight in just a second, which we're going to be activating. There are some other studies which will accept appendix cancer patients in addition to colon cancer, gastric cancer, and other things. I didn't put those on the list. But this is the whole thing. You talk about what do you do for, it's 5 trials. That's not a lot. So what are the research things that were going on here? What do? We have a HIPEC database with over 1,600 cases in, over 800 cases of cancer of the appendix. We're learning a lot about that. We do a lot with tissue procurement. We gather all the tissue, we snap freeze it in liquid nitrogen. It's available for initial analysis. We have a large tissue data set. We have collected what I believe is the largest tissue data set for cancer of the appendix on planet Earth, which we use to do research. Genomics studies is something I've been very active in. This has been supported by the NORD grant, which is funded by the ACPMP folks. Smith Family Foundation, which is a philanthropic group which has funded a lot of the research that we do. We do a lot of quality of life trials, quality of life for family member trials. And these are a couple of trials that we're going to be opening here soon. One of which is a study that we're going to be the North American site for a study which is using some enzymes to dissolve mucin. So rather than scooping it out, the problem with this stuff, usually if you have a fluid collection, you put a needle in it and you can draw it out. But this stuff, the mucin it's like trying to drink grape jelly through a straw. It just won't come. What somebody in Australia found, and please don't ask me how they found this because this amazes me, that there's an enzyme which comes from, are you ready for this? A pineapple, which will digest the mucin. So that and one other drug that we use to liquidate things we'll be looking at for patients who've got recurrent disease that you can't operate on anymore. Injecting some of this material, which will liquefy it, and you can draw it out. Now that will not cure you, but it can decrease the size of some of these collections which are putting pressure on the bowel. It can improve symptoms. So that's study number 1. We have another one where we're looking at a retroviral or a oncolytic virus. There are some viruses which we have taught to kill cancer cells. And we're trying to use those. Again, this is the first study, is a phase 1 trial that we're doing with the University of Illinois and Duke. And what we're going to be looking at is using an oncolytic virus, injecting that into the peritoneal cavity, and see if we can get some control of things that way with some smart viruses. This is a phase 1 trial. This is only for people who've had other things and have failed all other treatments. The organoid research, it's something Dr. Votanopoulos is going to talk about, something we're very proud of, which again, cutting edge, and the tumor bank. These are where our research efforts are. And before the sun sets on my talk, I want to leave you with a couple of things. Is this a rare disease? Every day of the year except today. You are amongst friends. Today in this room, this is the most common tumor in man. Okay, so I think that's pretty great, and that's, again, thanks to the ACPMP people for making that happen. We're seeing more of it than we used to. These are what's important. The experience curve in terms of going to a center, and there are a number of really good centers around the country. Morbidity and mortality rates are significant. These are still big operations. We're better at doing them than we were. Long-term survival is possible. I will also take another step and say cure is possible in some patients. We cannot cure all patients at present. We try hard. Okay, but we can't cure everybody, but some people are going to be long-term disease-free survival. Genomics, I think, is a great way to improve what we're doing, and I've been spending a fair amount of my time doing that. Extrapolating treatment to cancer of the appendix from cancer of the colon is the wrong thing to do for a lot of reasons. Appendix cancer is not colon cancer. If you get everything out, you're going to do better. If you add intraperitoneal adjuvants like a HIPEC or something into the abdomen, you'll have more disease survival, less additional procedures. We need more clinical trials for cancer of the appendix. Finally, this is not a sport for people who like to be on their own. Taking care of cancer of the appendix patients is a team event, both on the physician and the hospital side, as well as on the patient side. So, from the brave patients out there, and there are a lot of you here, that have gone through this experience from our HIPEC team to yours. Thank you. Thank you for coming.